Pushing the human body to its absolute peak physical limits during intense competition requires sustained, massive energy output. In preventive cardiology, moderate exercise is universally prescribed to protect against heart disease. The baseline lifetime risk of atrial fibrillation and irregular rapid heart rhythm affects roughly 1 in 4 adults. But for elite endurance athletes, the data reveals a paradox. Long-term high-volume training multiplies this risk by 2.5 to 3.6 times. Among older masters athletes, the prevalence of AFib reaches 5 to 10%, depending entirely on their specific sport and cumulative years of training. We expect elite competitors to have the healthiest cardiovascular systems on Earth. Instead, this epidemiological data frames their condition as a highly specific clinical anomaly. Extreme long-term cardiovascular endurance actively subverts the protective benefits of exercise, creating a cardiac environment highly susceptible to chronic arrhythmia. The standard electrophysiological intervention used to reduce AFib burden is catheter ablation. Ablation is a procedure that uses heat or cold to intentionally scar heart tissue, isolating the faulty electrical pathways causing the irregular rhythm. For the general population, this procedure is highly effective. Long-term studies show 50 to 70% of standard patients remain completely free from AFib at the 5-year mark. This comparative bar chart illustrates the efficacy gap. For endurance athletes, single procedure success stalls at roughly 60%. Even with multiple procedures, the success ceiling only rises to 77%. That leaves a stark gap. 23 to 40% will experience recurrent AFib. Comparative studies consistently confirm that at the 2 to 3 year mark post-ablation, athletes are significantly less likely to remain arrhythmia-free than non-athletes treated with similar strategies. Catheter ablation successfully treats the immediate electrical triggers of AFib, yet the high recurrence rate implies that the endurance athlete's heart possesses a unique underlying resistance to standard rhythm control. To understand why athletes relapse, we have to look past the clinical outcome data and examine the physical mechanics of extreme endurance training. Years of intense training force the heart to continuously move massive volumes of blood, creating a state of sustained high cardiac output. This constant volume overload leads to a specific structural consequence: left atrial enlargement. This is the physical expansion of the heart's upper left chamber. The atrial walls endure continuous mechanical stretch to accommodate the elevated cardiac output required during a marathon. This volumetric expansion is not a temporary state during exercise. It is a permanent structural remodeling, clinically referred to as athlete's heart. Clinical imaging studies directly link this larger resting left atrial size to a proportionally higher risk of incident AFib. This physical stress is compounded by increased vagal tone. Vagal tone refers to the activity of the vagus nerve, which slows the resting heart rate in highly trained athletes, but paradoxically promotes electrical instability in the heart tissue. The endurance athlete's heart physically deforms its own architecture to survive extreme workloads, directly compromising the mechanical integrity of the left atrium. Let's zoom in from the macrostructure of the enlarged atrium down to the microscopic reality of the stretched tissue. During peak athletic output, aggressive and repetitive mechanical shearing forces act directly upon the delicate myocardial tissue of the heart wall. The physiological response to this intense cellular trauma is the deposition of patchy fibrosis, which is microscopic scarring distributed across the atrial wall. This cross-section reveals the arrhythmogenic substrate. This mix of stretched tissue and dead fibrotic scarring creates an environment primed for AFib. The fibrotic substrate physically disrupts smooth electrical pathways, scattering the current into chaotic, cyclical microstorms. Ablation can burn away the immediate electrical triggers starting the storm, but it cannot erase the widespread patchy fibrosis already embedded in the tissue. The 23 to 40% ablation failure rate stems from the permanently scarred arrhythmogenic substrate that remains long after the surgery is over. Immediately following an ablation, an athlete often feels dramatically better. They are symptom-free and typically eager to resume high-level training. This symptom-free period creates a dangerous clinical illusion. the underlying atrial enlargement and fibrosis still persist entirely unhealed. This split-screen flow visualization shows the exact mechanism of relapse. Returning to high-volume endurance training immediately reintroduces elevated atrial pressures to the heart. This renewed mechanical stretch acts upon the existing compromised substrate to actively wake up dormant arrhythmic pathways. Keeping training loads within a moderate range prevents severe wall stress, allowing the ablated tissue to maintain a stable electrical rhythm. Currently, no long-term prospective trial exists to provide an exact percentage of risk increase for post-ablation athletes who refuse to slow down. However, despite the lack of an exact decimal point, the mechanistic reality and clinical observations definitively prove that continued extreme loading raises recurrence probabilities. Catheter ablation is not a curative reset button. Returning to the exact extreme mechanical forces that caused the AFib will inevitably force its return. When advising athletes post-ablation, electrophysiologists and sports cardiologists share a clear consensus. Strictest observation is required for high-risk profiles: older masters athletes, individuals with visible fibrosis on imaging, and those with persistent AFib. The primary medical directive is straightforward. Athletes must reduce their training intensity and volume, at least temporarily, while their structural baseline is carefully monitored. Continued activity and a healthy lifestyle remain the goal, provided they are managed through a modified training lens. Athletes must execute a deliberate behavioral shift, transitioning into moderate, sustainable training zones rather than maintaining chronic, extreme endurance loads. It is also necessary to aggressively manage secondary, non-exercise risk factors, such as blood pressure, sleep apnea, and alcohol consumption, to support long-term rhythm stability. Some athletes, specifically those with small atria and minimal fibrosis, may safely return to high-level training, but only under expert, individualized monitoring. Navigating this condition requires a specialized sports cardiologist who understands the delicate balance between a patient's athletic identity and their physiological limits. For the endurance athlete battling AFib, ultimate success is no longer defined by peak performance output, but by managing the structural limits of the heart to achieve a lifetime of rhythm stability.